Welcome, everyone, to another episode of the Sync podcast, where we explore the value of an inclusive approach in the way we think, work, and engage with our communities and workplaces. Here we challenge the idea that inclusion is exclusive. Instead, it's about ensuring that no one is left behind. Each episode brings you candid conversations with thought leaders and change makers who are driving inclusive innovation across various sectors. I'm your host, Nicole Piggott, and today we're joined by an incredible guest, Dr. Keith Thompson. Dr. Keith is a family physician based in London, Ontario, and the Chief Medical Officer at NuraLogix, a Canadian health tech company. With a career rooted in clinical care and innovation, he's also a board-certified medical affairs specialist and teaches at Western University. Dr. Thompson has been a pioneer in virtual care and telemedicine, contributing to national and global efforts to advance digital health through organizations like the World Organization of Family Doctors and the C.D. Howe Institute. I'm excited to talk with him today about the future of healthcare technology and patient-centered innovation. Welcome, Dr. Keith. So, Dr. Keith, welcome to the Sync podcast. It's great to have you with us here today.
Yeah, thank you, Nicole. I've been looking forward to this for many weeks since we first met. So, yeah, thank you.
It's going to be fun.
For
So
sure.
let's start at the beginning. Like, you've had a really rich, incredible journey, but I don't think most people normally think of technology, digital technology, and healthcare. And so talk to me what led you to blend the two and see the value of technology and how it could play a role in improved outcomes for healthcare.
Yeah, it's an interesting perspective as a family doc, right? I've been doing this for, 34 years now. And, to be honest, I was a late bloomer to technology. In fact, I was converting from paper to EMR the day that we announced COVID, which was just insane. We weren't sure we were going to be able to complete our training session. But, that was kind of my first foray into the applications of technology and how it might help us in encounters with our patients. But literally, I would say through the pandemic, kind of my aha moment was emoting to one of my former staff men here at Western. I'm adjunct faculty with the department, and kind of frustrated. We're seeing our patients by video. We're in lockdown. I mean, it was an incredibly stressful time. Not to mention the cutbacks in services. We didn't have fee codes for virtual care at that point. So if you can envision, I think it was 3 months without any income. We weren't certain how this was going to work. I found myself kind of going back to my roots, all of the early training under Dr. Ian McWhinney. I would say he's the forefather of family medicine, really globally known, but really the first to see and evolve family medicine into a specialty unto itself. And I started reading through some of his principles, and it just brought me back to what this role really is about, and that's a caring and it's a healing profession. But at its core, it's artisan or holistic. If you look at the work by Ursula Franklin, great thought leader here in Canada, she speaks a lot about this, that there's certain technologies which are prescriptive, and our EMR and some of the digital health, right? It's prescriptive, certain way of doing things, but how we interview and encounter with our patients and understanding their illness and the context of their world, man, there's no algorithm for that. And that's what really, I think, kind of got me charged. I'd been doing some early work with telemedicine and trying to figure out platforms within OTN and what that would look like. And serial fail, by the way, and trying to get some startups going. But it taught me a lot, right? In really the limitations and integrations of these technologies into clinical workflows. But it got me excited about some of the thematic data behind what it is that we do. And still that's an ongoing process for me, right? Learning from others. Yeah.
So it sort of came at you. It's so funny because, everyone we speak to, we all know the negatives that we experienced during COVID, but like it had forced us to look at the world differently and look at how we interact with the world differently. And it was a forced pause to kind of say, you know, the world has literally gone off its axis. Do I continue to act like it's the same old, or what can I do differently? And I love that it's been the source of innovation. It's been the source of going back to your roots. That's what I'm hearing you. Like you went back to the beginnings and said, what is behind my passion for family medicine? So, I actually met your organization through, speaking at a conference, and I was fascinated by this notion of NuraLogix and the notion of AI and the role that AI can play in improving health experiences and outcomes, and the role that technology beyond robotics and other things that we've sort of thought about in the healthcare space, but I've never ever thought about AI playing a role in healthcare.
Yeah,
And
yeah,
so I'd really love my audience to hear more about that notion of what NuraLogix is, what that technology
yeah,
means, and that whole
yeah,
notion of
yeah.
early detection, et cetera.
Yeah, yeah, no. So, again, I'm early in my journey, as I mentioned,
Yeah,
working with OTN. One of the projects we had started was to create this kit that we were going to take to patients that lived within
yeah,
participation house, high needs clients, bringing them to the office, I mean, with a van plus an attendant. And we realized that once Ontario Health opened this up and said we can do virtual visits, this is pre-COVID, mind you, we thought, hey, you know what? We can use a stethoscope and an otoscope and all of those tools and use the internet to examine the patients at home where they are. Saves the participation house over $200, $300 in transportation costs. Huge relief for the clients, not the stress of being transferred to the office.
exactly.
Easy for me. I can do an encounter on my laptop, right? So that initial kind of dive into how can I encounter my patients in a deeper manner than just video, not just talking heads. How
Right.
might I examine them? And that's how I discovered, and was introduced to NuraLogix, and was blown away by, the first day, the technology. I'm like, are you kidding me? Like doing video and getting vital signs? Like, how does that work? I mean, Arthur Clarke says, if technology is truly evolved, it'll seem like magic. And we still get that wow effect, right? When we demonstrate the technology, people are like, whoa. Now it's good and it's bad because then we have the clinicians and the scientists that are skeptics and maybe go,
Mm,
okay, explain this to me. And that's where I love my role now, right? Being able to tell folks, how does this work? Well, it's a novel form of remote photoplasmography. So that little device that we put on our fingers, be it at the dentist or we go to emerge or a doctor's visit, captures our oxygen level. There's a red light source going into our fingertip, and it can see the pulse wave every time the heart beats. And you'll see that little blip across the screen. Okay.
okay.
That's a form of photoplasmography. We're doing the same thing. Any camera, red, blue, green capabilities, 30 frames per second, we can see that pulse wave as reflected light changing. The light comes into our face, reflected back. The amount reflected back changes because of the pulse through the face as the vasculature opens up during the cardiac cycle. And we can actually see that pulse wave, not just in one region, the tip of the finger, multiple regions. So if you looked at our DEPA data, you would see these pixelated images of blood flow. We don't store the image of the person's face. There's no personal identifiers, right? This is anonymized data. We don't even know who we're analyzing, but we're capturing those images. What we've done is taken over 55, I think we might be close to 60,000 individuals, and brought them into the lab under their consent. We've
Right.
captured their pulse wave, right? Their transdermal optical imaging. You'll hear me talk about toy from now on. That's our, trademark terminology.
Right.
We can see that data pattern in the face, but now over 55, 60,000 individuals, we have their cholesterol, we have their blood sugar levels, we have their blood pressure measured by auscultation, right? Ground truth. We know exactly what that reading is at the time we do that scan. Imagine that over tens of thousands of patients. We can use the AI and machine learning to start to recognize, oh, well, I know what blood pressure is if I squeeze your arm and listen, but what is that same reading in that data pattern in the face? And it's then, I mean, I'm simplifying it, but it's a data match. It's a different set of parameters that we're seeing matched to a known ground truth based on, medically approved measurements. We're still investigational, got to clarify that. We're working towards getting these parameters cleared through the various regulatory bodies, and we're excited about that. But that's really how the technology works. It's not as mysterious, right? And the neat thing is blood flow is blood flow. So
Right.
we're using large data, but based on ground truths, so that some of the algorithms out there that might be difficult because of social determinants of health. I know we're going to talk about that today,
Yeah.
right? How does that work? Well, social determinants, yes, may affect your health outcome and may
Right.
affect your atherosclerotic or diabetic risk, et cetera. But at the end point of what is going on within the vasculature, that's the same across all the populations. And so we have a very heterogeneous population set that we've tested and trained this on. And now we just have to prove to those regulatory bodies that, yeah, we can use this across a wide population set. So it's going to change, I think, as a clinician. I get excited because I go, wow, like how many people have one of these in their pocket,
Exactly.
right? And I don't need to buy another device or a wearable. It's something I already have, so that I can reach into those populations and see what's going on. So that's really cool.
Listen, for my audience, I want you to understand this thing blew my mind. So I went to the kiosk at this conference and had the scan done. It takes no time whatsoever.
30 seconds, yeah.
30 seconds, is it? Okay,
Yeah,
because it
yeah,
was
yeah.
wild. Like I literally, and I have to say, I was one of those skeptics. I thought, okay, I've got this, fairly rare condition. Um, and I thought, oh, it's never going to pick this thing up. And so the real clincher for me was front and center in my report was it highlighted that I likely had this, and I do.
Yeah,
And
yeah,
so I was blown away. And at that point I said, this could be huge. And
yeah, yeah,
so, and really, Dr. Keith, you and I have talked about the fact that I spent a huge portion of my career working in remote communities.
mhm,
I've worked in Northern Canada. I've also am the chair of an organization that works in conflict zones in the Southern Hemisphere, largely in Africa and the Congo. And so
yeah.
the possibilities of something like this for remote communities is huge. So talk a little bit about the role that NuraLogix and frankly this AI technology can play in
Yeah.
bringing healthcare to people who are underserved.
Yeah, no, no, absolutely. We have a full suite of different measures or
Right.
parameters that we do, and some of them are direct measures. I mean, blood pressure by this analysis of facial blood flow is a measurement, but then other analysis we do would be classifier models, and it reports back what is the likelihood that you may have a certain
Mm,
condition, elevated cholesterol, diabetes, for example, or fatty liver. If you think of the traditional way of assessing risk for that, it would mean going to your doctor or healthcare provider, maybe an initial history, getting a lab rec, getting a blood test.
right.
Maybe if you're lucky, it's point of care, but usually it means going to a lab or someplace else. Those services, heaven forbid, if they're even available in some regions of the world, let alone the time and the workflow needed to get that. We can do that analysis within that 30-second scan and determine who may be at risk. What's interesting about that is, and we've had some example workflows, we've been approached by some public health organizations and saying, look, we want to do an analysis across a region and there's, 500,000 people. We want to know what is the risk of diabetes or hypertension or what's going on in that community. It
Right.
would take an army of nurses and physicians and lab. that we could do that with a scan and determine a heat map, if you would, with a really high negative predictive value. And that's the other key. So we'd say if you screen negative, likely you don't have that condition. We can say to that person, you're good. For those that screen positive, now this is where it gets tricky, because as wonderful as the technology is, okay, we've done the test, we've done the screen. Now what? Because now we need that intervention. And, I think, probably we'll talk about this more, but as you're aware, and there's certainly certain populations and indigenous communities, I can't just come in with my device and say, let me show you how to use this. We need them at the table to partner and say, maybe the concern isn't hypertension or diabetes, there may be mental health, there may be other issues, which we can, by the way, determine mental stress by doing these analyses and scans. But in working with these communities and helping them design or co-design what would this look like, I think really is a game changer. And we need that connectivity for sure. We got to have internet access. And some amazing work being done right here in Canada. Check out Scott Brass, by the way, Eagle Flight Network, and no conflict of interest. Scott's doing some incredible work in getting a line into these communities. And Scott gets it because he said, Keith, it's not just about healthcare now and the connectivity, it's social determinants of health. And that line into the community can create microeconomies that they themselves can participate and develop wealth, right? And I think, wow, that's cool. And we're not yet into that work here in Canada. We've done some overseas and elsewhere, but certainly open to those possibilities.
I think that's fantastic, because one of the things for working in the space that we work in and having a keen understanding of the histories of some of these underrepresented groups, there's going to be a huge level of skepticism around, is this technology designed for me and my community? Because we've had experiences such as the blood ox meter during COVID that really underserved people from the Black community. We saw, that the poor readings for people from the Black community, and often acute outcomes for a lot of those people. We had deaths associated with, and there's a huge lawsuit associated with that very issue. And so there is going to be, due to those historical experiences with the medical world, and particularly the settler world on those communities, is this another way to test your stuff on us, and that it's not going to work? So how do you get over that? How are you, you talked about working with leaders in the communities. Talk to me a little bit about how you've managed to get through.
So, in some of my other work, certainly at Western within the Space Institute, I'm involved in the C2, M2, some of their projects. And that's how I met Scott Brass, for example. And quite frankly, just honest discussions and trust. I mean, this is not a situation where we can come in and pop up a kiosk and expect to start to serve, right? No. We have to have ongoing and relationships. And so trust is of paramount importance. In fact, one member of the community up north, the First Nations, told me that, bringing these medical modules into remote communities and trying to serve, fascinating, Keith, but keep in mind that during the residential school program, the first thing that happened was a medical van would arrive and the kids would come and get their examination and disappear and never be seen again.
Exactly.
So how traumatic. We can't reproduce that, right? We just can't go back there. And we have a lot of making up to do. I think we talk about reconciliation, but my gosh, I mean, 44 kilometers from where I sit here in London, Ontario, we have a community that's on boil water advisory.
Yeah.
Several times. And that to me is insane. So I think the first step really is just developing that trust and then asking with permission, what do you need, right? How can we help? And what might that look like?
To me, what you're hitting on, I want my audience to hear this as a learning. We cannot apply our typical approaches and our typical sort of westernized approaches to inroads into these communities. And sometimes we can get frustrated by how slow the process is to get a foothold to even start to get to the solutions. But that investment of time and effort in building trust, listening, developing relationships with people within these communities that have been injured by settlers historically, and therefore have a rightful skepticism around any sort of overtures, is an investment in absolutely achieving success with the implementation of some of these solutions for those communities. So hearing you say that is so crucial.
Yeah, I think that's true, Nicole. And I think it, behooves each of us within this realm to ask ourselves, are we, creating or designing a solution? Are we approaching these communities because they are a potential market?
Yeah.
Or are we approaching because we want them to be self-serving and develop their own solutions and innovate? And I think that's, back to the idea of the connectivity and letting them design what would work for them. And there are a few examples of that within some EMR programs, right, that are catering to First Nations languages, et cetera. And I think that's a start. We have a long ways to go for sure.
Yeah.
And it's shocking, right? That Joyce Ketchwan, if I'm saying her name correctly, in
Yes,
Quebec, that horrible story, right?
absolutely.
And that's not more than how many years ago? I say, really? Yeah, I had one lady explained to me she would not let her father go to the emerge alone. He had a cerebral palsy, but would instantly kind of be seen as, on substance or alcohol abuse because of his impairments, right? Which were
Exactly.
physical, not neurologic. But so learning, and I think if you're working in that area, imperative that you take a cultural safety training. And Sanyas, I think, is one. There's some good programs out there, and then just explore locally, right? We have opportunities to learn and visit, and don't be afraid, right, to approach and just be willing to listen.
To learn, and I love that. You're telling your story. So for my audience, those of you who don't know, we had a situation here. It was around COVID. It was during the COVID period that we had a young Indigenous woman who was calling for help. She was at the hospital calling for help and was ignored and
Yeah,
chastised, and then she finally passed away
yeah, yeah.
without help and without aid. And she was actually ridiculed and denigrated during her stay, with the typical tropes that we see towards Indigenous communities here and frankly elsewhere in the world. And so and just from a personal experience, I was in the hospital with a friend 2 years ago. She was in the emergency, and there was an Indigenous woman beside her who was under the influence, but the level of contempt and disdain and dismissiveness that was visited upon this woman, instead of empathy and kindness and understanding. And I understand people were frustrated because people who are under the influence can be frustrating to you because it's hard to get through. But I just sensed that the frustration was eclipsing the ability to help this person. And I finally couldn't help myself. I wasn't there for her. I was there for a friend. But I went over and I said, listen, I know you're frustrated. And I can completely appreciate, I've listened, I can appreciate that, she's frustrating. But
Yeah, yeah,
ask
yeah,
yourself what brought her here. And that could be your sister, your aunt, your cousin, that could be someone in your family. And you would hope that if they were in the emergency, that a colleague of yours would be treating them with kindness and care. And so
yeah,
just
yeah,
try to keep that in your mind when she's driving, like when she's driving you crazy, because
yeah,
she
yeah,
she needs your understanding and help. And part of her reaction is reacting to the hostility that she's getting from you. And
yeah,
I can
yeah,
see it, and I'm in two breads over. So,
yeah. No, listen, Nicole, I'll tell you, I've had an experience I would say has blessed me in many ways in being able to meet an Indigenous artist, Melanie Montour. First encountered her in a conference up north in Timmins and Cochrane, Ontario. And attending the second year, we drove Melanie up to the conference. So we're in the car together for 8 hours, right?
Oh,
And
okay.
hearing her story
Yeah.
as a 60 scoop survivor. But I tell you, doing a course is one thing and learning and doing the modules, but hearing it firsthand from someone just totally changed my experience. And I would say, listen, I'm not a leader in this space. I'll be honest, right? There's a lot of things I'd like to do and still endeavoring to do, and would like to see these technologies be able to serve. But the first step at understanding really what true reconciliation is about. And just hearing Melanie describe what she went through
Yeah.
as a young person, right? And to be able to tell her, actually, I'm sorry, was a pretty powerful moment.
Yes.
And I won't forget that. As I said, kind of uh, put a signature on my heart. Really, what are we doing within healthcare? And as a family doc, what's my role, right?
Yes,
Uh,
exactly.
so it kind of brings you back, as frustrating, as chaotic as everything is. And that the technology is not just the full solution. It can do wonderful, incredible things, but it needs to be partnered, right? We kind of need that hybrid of
So
compassion and yeah,
talk to me about that because to me, NuraLogix and the notion of AI and the ability to sort of give you an initial assessment, because I see it sort of like an assessment tool. It gives you an initial
yeah, yeah,
assessment. Now, where do you go from here? And you talked about working with communities to help them to take the next step because it's you get a diagnosis or you get an assessment. Where do we go from here? And you and I both know, and I've worked in the in like I said in remote communities where okay, I've got an assessment, but the next specialist is an 8 hour car drive away or a 4 hour plane ride away that comes once a day and costs $1,000 for me to get to the nearest physician. And
yeah, yeah.
so how like where do we go from here?
Yeah, again, not that we're directly involved in these
No,
projects, but I certainly can give you some really amazing examples. Ivar Mendez, right, in Saskatchewan, and has worked with the First Nations there. They have this incredible virtual hub that was designed by and for Indigenous communities, and it looks like something you expect at NASA. They have all these video terminals and their remote connections into these communities, like literally, hundreds of kilometers away. 70% of the medical services are now providing in community on site, not having to bring people to the south. He was
right,
explaining to me one tool, for example, they use is an infrared scanner to check for subdural hematomas. So I have a fall or I have a potential bleed in my
right,
brain. Normally, it would have meant we got to fly you out for a CT to determine that. Now, with this tool, right, they're able to do a screening exam and determine with a high negative predictive value, again, back to if it screens negative, we're good. We can
right,
watch you here, right? Dramatically reduce transportation costs. But they can do remote ultrasound, right? Remote robotic surgery in community or in-house. And I think that's where the ancillary services that we build. And I like that project. I speak about it often because I think he really is a hero of being able to work with a community and design not just the technology for the screening and the assessment, but those interventions that follow up.
right,
Globally, Aaron Jose, a group out of the Center for Chronic Disease Control in India, have a telemedicine platform where they take community paramedics or community health workers empowered by these AI tools. So again, envision a tool like ours being able to
right,
screen at the local pharmacy, right? Those that test positive, okay, we can do further testing or point to care. But the person driving it or in control is part of that community. So they have that trusted, you know, relationship. They're a social Sherpa, if you would,
Right, right.
to bring this technology in. And I think that's a fascinating model because they're serving areas that are very remote or high density urban, 40,000 people within a region, and there is no physician available, right?
I've been to India and I could see how that would be hugely beneficial to a huge population that often, to your point, it's like by foot, cow, uh,
Yeah,
to get
yeah,
to an
yeah,
urban center. I've been
yeah,
outside
yeah.
of New Delhi and it's, hard to
Yeah,
get to anywhere.
we're sometimes in a bubble here in the developed world, right? We
Yeah.
forget what's going on
Yes.
elsewhere. But that concept that a pharmacy might be your point of care or point of need, is really fascinating to me. So this technology, I think, is definitely a game changer. The intervention supporting it, I think, is where we still obviously will have work, and that's what COVID revealed, that digital divide. People that just didn't have access. I mean, I still use a telephone a lot for some of my virtual stuff because it's easy access. But I need to match the modality to the patient needs as well. And so,
Right.
we won't say that this, technology works well for some. In some circumstances, it's back to the hands-on and the face-to-face. I
Right.
remember a lady with a serious cancer. She was end stage. And I thought that a video visit was going to be perfect. The daughter didn't have to come from Toronto to bring her to the office. And if she was terminal, we knew that the end point was, what that entailed. And so I initially spoke to her and said, hey, let's set up some video chats. And it was more mental health and stress and
Right.
anxiety. And she, at the end of the interview, she says, oh, Dr. Keith, says, I really want to come and see you. I'm not much for this video thing or computers. And so then ensued, the regular visits. And I would feel for lymph nodes and listen to her lungs. And I thought, this is a futile maneuver. I mean, but it reassured her, right?
Exactly.
And she needed that. And that was so therapeutic. So we can't lose or replace always
Right.
those kinds of relationships. So I think even in these communities that are marginalized, we need that hybrid model. There's got to be somebody there beside you when it's needed, right? And when
Uh,
appropriate.
but what I'm hearing from you is it allows us to be really targeted, and those people who they can easily be served by this up to a certain point, you at least don't spend the resources, the limited resources, the limited both financial and actual healthcare professionals. We have a shortage of family doctors. I don't know what it's like in Ontario, but Quebec, we've got a 6 year, 4 to 5 year backlog to get
Yeah,
yourself a family physician. So if you had something like this to sort of take away to build capacity in the system
right,
so
right.
that kind of
Yeah.
intervention is for those who need it, that I think that's a win-win.
I agree, and I think it will challenge us to rethink how we deliver primary care in Canada. And I think we'll go through some birthing pains,
Yep,
truthfully. I
yep.
think even within my colleagues, the idea of task shifting or decanting what I might normally do to someone else, be it a community health worker or RPN or whoever, empowered with this technology that allows them to do what
Right.
I once did, but by increasing capacity. Some of us may grit our teeth and think, right, again, back to Ursula Franklin, she talked about that wanting to control technology. It becomes the
Exactly.
power of the elite in some ways,
It
right? We
does.
don't want to let go of it. But we're seeing now, we're past that. I mean, the genie is out of the bottle. You can go into Chat GPT and it's amazing. I, had a patient, it was going to be 18 months, if you can believe, to get to a dermatologist. And I had tried other avenues and they're like, no, I just couldn't get this person. I said, you know what? Do you mind if I take a picture of your rash? And let's load it up to this system and see. And not endorsing this as a medical
No,
software, right? But oh my gosh, like it described the annular margins, desquamating central
the
pallor,
whole thing.
the whole thing. Have you suggested? It gave me a list of differentials, what I should do. I'm like, wow, that's basically an e-consult, right? Did it save me time and frustration? I was ping-ponging referrals. No, sorry, Keith, we can't see that problem. No, it's 18 months. No, there's not, you're outside of our area. We can't accept this referral. Oh,
I mean,
right.
18 months without relief, that's the difference between 18 months without relief and at least some relief, but between that point and getting a consult with a dermatologist. This is what to me, it's super exciting. And, you mentioned something that the case in India that really resonated with me because, I go into the pharmacy over here and I'll put my arm in the cuff of the blood pressure reader. Blood pressure's good.
Yeah, 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 good.
But I just for fun, like, I mean, I'll just test it. And I think that like just for the folks's benefit, and you'll at the end of the podcast will be the links to NuraLogix, so you'll be able to check it out yourself. But if I could see something like that, a kiosk in pharmacies,
Yeah, yeah,
that
yeah,
would, and then linked to here in Quebec, we have something called the CLSC. There are public health clinics, so to speak, that do a lot of care between your
yeah,
physician and the emergency care in the hospitals. And so I could see that being some sort of system
yeah.
that's related, connected to
Yeah,
that.
yeah. No, that's exactly the discussions we're having with the Magic Mirror, right? Which was our
Right.
latest
Yes.
version of. And so, yeah, it's sometimes everyone's camera is different, the lighting is different.
Right.
So we've, been able to control for those circumstances. We control the camera, control. It is now a one-stop shop in terms of device and configuration to get those measurements. And absolutely, yeah, that's what we're envisioning as well. Is you have this in the pharmacy, or gosh, maybe it's in a mall, maybe it's in a fitness studio,
Yeah.
maybe it's in a nursing station in a remote community. And we had some early experience with that in regions of South America where folks were coming down from the upstream and really remote rural areas and coming to these, pop-up nursing stations to try and determine, risk of various diseases. We have 1 billion people with hypertension in the world, and half of them don't know that they have it, which is a crazy statistic when you think about it. If we could simplify just the process for screening, just to determine, yeah, you might have this. Okay, let's examine more and clarify or validate what we're seeing with the screening tool. Yeah, like, man, what we could do with that.
Wild.
So I think that's where this is going to go. Our other platform being the telemedicine, and we can capture these signals and measurements during it. So if I had this plugged in, I could say to you, Nicole, hold still for a sec, right? And during the telemedicine, right, get a capture of your measures. So that's another workflow that we envision with these kiosk being set up. Well, then
Right.
might there also be a potential for a telemedicine feed to a physician as needed? But yeah, it's crazy where this technology might take us. Yeah.
Incredible potential. So, Dr. Keith, at this end of this segment, we always ask people to share with us, how do you make sure in the work that you're doing, because you do family medicine. So folks, Dr. Keith still sees patients in the traditional way as a family medicine,
Yeah.
as a
Yeah.
family doctor. He also is a professor at Western University and in London, Ontario, but also is working with NuraLogix. So how do you make sure that your values are always reflected in the things that you do? Because you're a real ally and advocate for underrepresented groups and underserved communities. And I hear that in what you say and the humility and humbleness that you bring to the work that you do. How do you make sure that it's always a guiding principle for you?
Yeah. I, you know, I think just looking for opportunities that I might bring others to the table,
Mm.
and whatever that may entail. And maybe we're planning a workshop or a conference and suggesting the idea, how might we look at this from an Indigenous perspective, or how might we look at this from a patient-centered care. So my core value, if I would say, and reconnecting with my former staff people, right? It's kind of 62 years of age, and I feel like a student again. That's a little weird, but it's been incredibly rewarding. But those core values being what's important for the patient. And I know we have to balance it because it is frustrating, right? I have to go through certain workflows and
Right.
the meso, the micro, the macro barriers and facilitations to all that we do. But I think it starts with really just having those conversations and being brave enough to introduce the topic, right? And listen, I don't consider myself at the forefront in terms of the work within marginalized populations. And there's certainly people have done way more than I am, a technological guru, and excited about that. And I want to see this grow. But man, Dr. Bouzerie, I believe in Toronto, right, has done some work with the homeless, and I think recently got a Governor General's Award for that.
Yes.
Some really outstanding people, right, that would know more about this space than me. But I think being willing to learn and say, okay, how can I change what I do, or how can I influence those around me with the conversations is a start. I had a great role model growing up. I'll tell you, my dad worked as a factory worker. And I'll never forget that early in the 80s, there was a diaspora of people from Vietnam coming to Canada. And
Yep.
they set up in the factory where my dad worked. They couldn't speak the language. And the fellows would sit in the cafeteria by themselves. And, there was a usual sort of comments about, not speaking English and what's,
Mhm.
why. And my dad went over one day and sat with them. And they started sharing food and explaining in different language what an apple is, what you're right. And it changed the atmosphere within the shop.
Yeah.
And suddenly it was like, people were kind of learning to say hello and goodbye in Vietnamese. And probably after several years, we were invited, to a dim sum with the family.
Mhm.
But the impact on me as a teenager to see how my dad responded to that, right?
Yes.
And being able to include rather than just look, and not make that effort, willing to walk across the room and make those friendships or reach out. I think that's where it starts. Everybody has a story. Everybody
Yes.
has a story. We just have to take the time to listen, right?
I love that what you're talking about is role models. People are watching, folks.
Yeah.
Young people are watching you. People who admire you are watching you. And the way you behave either endorses exclusion or endorses including people. And I call it building a bridge. What your father did was building a bridge for people who have gone through a horrific experience. I went to school with kids who came over during the crisis in Cambodia and in Vietnam.
Yeah.
And I remember, I mean, as a child, I didn't appreciate the trauma these kids had gone through. But what your father did was reach out to people who have to your point, a story. And that story, you and I had the privilege that we didn't have to live a story like that. And so what that, a little gesture like that, which probably was nothing for your father, what that meant to a person who is traumatized, feels hugely isolated, and is isolated even linguistically, is a terrific example. And so I was going to let you go, but I have one other thing that what you just said triggered for me, because I used to be on the board of the McGill University Hospital Center here in Montreal years ago when we were building our big facility at the Glen site here. And I remember at one point I was walking around the children's hospital, and a child was being difficult uh, and fighting the nurse who was trying to administer care.
Yeah.
And I stopped, and I was a young mother at that time. So this is
Yeah.
30 over 30 years ago. And I went over and I said, can I help? And I talked to the little boy, and what he revealed to me was he was not understanding what they were doing. They were just doing what they had to
Yeah.
do, but they weren't explaining to him what was happening. And the last time he had not asked questions and not gotten information about what was going to happen to him, he was put under for surgery, and he thought he was never going to see, the way he put it was, I'm never going to see my mommy and daddy again. And
Yeah.
that was what was running through his head when he was like, if I submit to this woman, am I,
Yeah.
what does this mean?
Yeah. Yeah.
And we implemented at the university a patient education program where patients came in and spoke to young med students about what they were hearing when you were talking to them.
Yeah.
And
Wow. Wow.
that's what I'm hearing from you. It's like connecting with people, talking to them. What do you like as a professor? How are you making sure that the next generation of
Yeah. Yeah.
students have
Well,
this
I'm
notion of empathy?
I'm adjunct faculty. That made it clear I'm a pseudo
Yeah.
prof, right? But
Okay.
yeah, no, no.
Pseudo.
It's honestly one thing I've learned over the years is I thrive on visiting with people,
Mm,
and I enjoy it. You don't want to be the last patient in my clinic in the afternoon because I'm going to talk your ear off, right? And my wife used to work in the front when she was before children, a social worker, and she's like, Keith, you got to let them go. My gosh, you're going to talk like they want to leave, let them, right? But that is a reward,
yeah.
honestly. And as I said, in discovering what people are about, what's their journey, and how that relates to their illness can give you some incredible insight. We're so caught up with efficiency in the
Yeah.
system and throughput, and we're losing sight of efficacy. The
Mm,
tools, the AI scribe, it gives me extra time with the patient because it
mhm.
saves me from doing notes. Wonderful. It gives me back that currency. But how do I want to
Right.
spend that currency? I want to spend it having a little visit with people if I can, and the Ministry of Health is going to shoot me for this because say, yeah, you're supposed to be seeing 88 patients, a week or whatever. And I'm like, no, but that's the thing we lose sight of, that efficacy. That's what makes us thrive as family physicians. I mean,
Exactly.
McWhinney said that, efficacy has a higher value for us as primary care. And if we lose that, God forbid, we lose a lot of what healthcare is meant to be. One last shout out, AMS Healthcare, right? Compassion and technology. Check them out. We've been to a few of their conferences, and this is their burden as well. So there's a community of interest out there, and
Right.
thank you, Nicole, for this chance, right, to speak to you. It's exciting, right, to meet
It
others that are
is.
passionate and so, wow, I'm in warm water here, right? So this is good, really
Well,
good.
it,
Yeah.
it was been great having you. I so appreciate your joining our inaugural year of our podcast. I could not have thought of a better ambassador for what I experienced when I experienced the NuraLogix technology. And I love the humanity that you bring to this. I love the curiosity that you bring to this. And so I want to thank you, Dr. Keith, and I hope we get to have you back. All of your information will be in the information section of the podcast. Please check us out on YouTube and all of your podcast providers. And you will learn more about NuraLogix. You'll learn more about Dr. Keith, and check out the rest of our other podcasts in our series. So thanks again, Dr. Keith, for joining us.
Thanks so much, Nicole. Appreciate it. Thank you.
Thanks for tuning in to the Sync podcast. If you enjoyed today's conversation, be sure to like, comment, and subscribe. The Sync podcast is brought to you by Synclusiv, where we're building inclusive workplaces that work for everyone. To learn more about how Synclusiv can help your organization create real, measurable change, visit synclusiv.com. Until next time, stay in sync.